So for our first presentation today, we really wanted to set the stage from the provider perspective. And I'm very excited to have Theresa Lampl here with us today. She is the Chief Executive Officer of the Ohio Council of Behavioral Health and Family Services Providers. And in thinking about this, I think I've known Theresa like literally half of my life. So really excited that she could be here today. The Ohio Council is a statewide trade and advocacy organization located in Columbus that represents 160 private businesses that offer community-based prevention, addiction, mental health, and family services. In this role, Theresa advocates for public policies that support the health and well-being of individuals and families through access to a comprehensive, integrated, and family-centered continuum of care that's inclusive of prevention, early intervention, treatment, and recovery supports. And we'll be touching on a lot of these topics today. The Ohio Council supports its members as vital healthcare providers, businesses, and employers. Theresa has more than 25 years of experience in community behavioral health service delivery, public policy, and advocacy. She's held both clinical and administrative positions in community behavioral health organizations, working with adults, children, and families prior to joining the Ohio Council in 2005. She has a Bachelor of Science degree in Psychology and Business from Muskingum College and a Master of Social Work degree from The Ohio State University. Theresa is a licensed independent social worker in Ohio. So I will turn it over to Theresa. Oops.
Okay, great. Well, good morning, everyone. It's great to be here and great to make the trip down south from Columbus. I'm going to start by saying, let's take a moment just to be grateful for today. It is November. It is sunny. It is 60 degrees. So we're just going to take a moment to remember and reflect on the good things, because the data that I'm going to walk through is daunting and challenging, and the work that you do every day is daunting and challenging. And I want to take a moment to just say thank you to every single person in this room who's working to solve the challenges of mental health crisis, of addiction, of the many challenges that come with poverty. The work that you do is incredibly important, and you don't hear thank you enough. So from me, as one of you, I want to start today by saying thank you for what you do, and know that we still have a long road in front of us. I'm not going to say that I have any of the solutions today, but we have ideas. And I think the point that was mentioned earlier about it's all local, healthcare's local. So how do we solve the problems that we have here today? How do we collaborate with each other to find solutions? Know that we're sprinting marathons, right? I mean, COVID has felt like sprinting marathons. We're still going to be sprinting marathons. But if we do that work together, we can pass the baton to each other when one of us is weary and tired, and we can keep going. So that's my opening. I just want to say thank you for what you do, and I'm grateful to be here, and I'm grateful that we have such amazing partners. So a little bit about the Ohio Council. Tracy gave you the general overview. We are a statewide trade and advocacy organization. We represent about 160 of Ohio's community behavioral health programs across the state of Ohio, and you can find more information about us there. Before I start talking about the behavioral health workforce, I want to lay the stage to talk a little bit about the general labor market workforce crisis, because we're a microcosm within a larger workforce challenge. So one of the biggest challenges coming out of COVID, or not that we're completely done with COVID, although we'd like to think we are, is that the workforce participation rate in general dropped by over 4%. 4% doesn't seem like a lot, but when you start to build these things together, you're going to understand that the bigger issue is we have a lack of workers. So that 4% loss has, in 2020, starting in March of 2020, has only slowly started to rebound. It's still sitting at about 3.8%. So we still have a long way to go just to get back to baseline. There's also been a very significant demographic shift, particularly with retirement acceleration that, again, happened somewhat as the result of the beginning of the pandemic. When you look at the healthcare workforce or the essential workforce, what we find is that about 37% of our workforce is over the age of 55. When you compare that to the general labor market, that's only 16%. So we also have this shift of we have a lot of older workers. We're also in a state that is graying more quickly than other states, and we're losing a lot of our young people. So this demographic impact on our workforce is very significant. The other thing we don't think about is the COVID deaths, but also the impact of the overdose epidemic. We have lost a significant amount of workers due to both of those epidemics and chronic health conditions. So these are all the factors that are just impacting the significant just availability of the workforce in general across all industries. And what does that result in? A really significant challenge in wage acceleration, particularly for entry-level jobs. So if you look at just the basic data, we've seen a dramatic shift in competition for the workforce, particularly in behavioral health. So I've included some data around home health care workers. So in 2020, and this is a terrible number, terrible, the average rate of a home health worker was $7.18 an hour. By 2021, that doubled to $13 an hour. A behavioral health case manager is averaging around $15 an hour, and if you're doing residential or direct care, it's about $13.65. Now compare that to our new competition. Amazon, Target, Dunkin' Donuts. Dunkin' Donuts is my favorite because at one point during the pandemic, when we were meeting with CEOs on a regular basis, we were talking about how much are you paying? And the winner at one point was a Dunkin' Donuts in Chillicothe that was paying $20.20 an hour. So it's a simple math problem around how do we compete. And when you have fewer workers, you're trying to compete with these bigger challenges. So this is some of the issues that we're facing just in the general labor market. It's no longer, am I competing with a hospital? Am I competing with an insurance company? Am I competing with the VA? We're now competing much more globally. We're competing with Amazon. We're competing with Walmart. We're competing with Target, Dollar General. Everyone is paying equal or more than what we're paying for entry-level positions, which also has an impact on students when they're considering careers, right? So these are the general labor market challenges. But then you move into the healthcare space, and like our counterparts in physical health, we're just seeing a severe shortage of workers. Everybody's looking for a nurse, right? Everybody's looking for a social worker, a counselor. We're looking for case managers. We're looking for van drivers. And the problem really comes down to is that with the pandemic and all of the other social challenges, we've seen a rise in demand. At the same time, we're seeing this decline in access of professionals, which means we're running into a system that where hiring and retaining has just simply been made worse. So on the front lines, what it means is that clinical and medical staff are hard to find, easy to lose, and very costly to replace. And it's this mismatch between the need and demand that is really delaying access to care, and it's creating challenges for continuity of care, and it's really challenging the sustainability of the system. At the end of the day, for me personally, what I find, and I think this will resonate with you, is the behavioral health workforce crisis is first and foremost an access crisis. We simply don't have the ability to meet the demand for the number of people seeking care. Again, this should be nothing new to you. When we look at the health professional shortages, this is mental health, and we look at the region in the state of Ohio. I'm always questioning, why are there still counties in white? Because if it's really a math problem, we know that there's demand and access issues everywhere. But certainly in the Appalachian region, it has been a long-standing challenge. I know when I was in college, I was at Muskingum, and Laura Lee Porter was one of the professors who did a lot of work on Appalachian study. And the map that you talked about, John, was really, she had that map and it showed how much of Ohio really falls into the category of Appalachia. And certainly working in some of the northern areas, around Franklin County, when you get up to Marion, you don't think of Marion, you don't think of Mount Gilead, but they're very much similar culture. So we have this huge swath, including all of the areas down here and around you, all the way up to the lake, right? So we know that we have significant challenges. So according to HRSA, and just their calculation of who has a degree and who lives in certain areas, 67% of our counties fall into a health professional shortage for mental health. Between 2013 and 2018, we knew that 21% of Ohioans had a diagnosable mental health condition, at least one. Recent data from 2021, put together by the American Psychological Association, shows that that number in 2021 jumped to 41%. So we doubled the demand in terms of the need for care. So what does it really mean? So the Department of Mental Health and Addiction Services did an actuarial study, and this is pre-COVID data. So this is from 2013 to 2019. And what they found was that the demand for mental health services increased by 353%. 353%. Now our workforce grew, but our workforce only grew by 174%. So what does that mean? It means that in terms of just people who have a need compared to every single licensed professional. So we took everybody who could treat a person with a behavioral health condition and we put them with and matched them to a person in need. My caseload would be 380. Now, let me do a little basic social worker math for you here. If I saw a person 1 hour a month and I worked 40 hours a week, every single week for that 30-day month, I could see 180 people. What does that mean? That means 200 people would not be able to be served. So at the end of the day, what we have is a significant shortage of just people available to serve those with needs. So because we're here and we're talking with the Appalachian Children's Coalition, I wanted to include some data around kids and families, because we know the impact on our children and families, particularly with the shutdown, with the social isolation, has really dramatically shifted the challenges that we're seeing with kids. We know that our schools are routinely saying we need more help, we need more help, we know what we need more of. In October of 2021, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatrists, and the American Children's Hospitals declared a national emergency in child and adolescent mental health. Shortly thereafter, the U.S. Surgeon General, Vivek Murthy, issued an advisory on youth mental health. And why did we do this? Because if you look at some of these numbers, a significant increase, 57% in youth suicide rates in the decade before COVID, a 44% increase in high school students that reported significant and persistent feelings of sadness. And the average length of time that it takes to get treatment, 11 years. We simply have to do better. And then if you look at recent data from Nationwide Children's in terms of the impact on families, they issued a report called The Great Collide. And this was really looking at what's the impact on our families when you have a child who's experiencing a mental health or a behavioral challenge. So 53% of parents reported they missed at least 1 day per month due to their children's mental health issues. And 30 to 50% of parents thought about their children's mental health issues while they were at work. And then 53% of parents or caregivers said their work was impacted by their child's mental health or behavioral health challenge. So the impact indirectly on our parents and impacting our workforce is very, very significant. We know we have a lot of need. We have all kinds of challenges in terms of helping the next generation be prepared to be resilient, to be productive, and to be able to help their children be successful in whatever field they choose. So the Breaking Point report that we released is really to look at, what's happening from the perspective of the community behavioral health provider. And we gathered this data about a year ago. I would venture to guess if we did this survey again today, the impact would only be that we need more and that the demand has increased even more. But we had 68 of our members that reported and responded to this survey, and nearly all of them reported higher demands and then bigger challenges in recruiting and retaining staff. So some of the key findings was that 70% of our members reported that they saw an increase in demand for mental health services for kids and adults. 60% reported an increased demand in substance use services for adults. So why is this demand so high? Well, I think it's important to realize that, one of the silver linings is behavioral health is viewed as essential health, at least in some communities. But in most communities, we're really starting to recognize that brain health is critical for overall health. We know that pandemic stress was real. Everyone experienced it, including the helpers. So the helpers who are helping experience stress, but in general, demand is high because everyone has been impacted. The pandemic just made some of the social economic challenges and the issues of poverty even worse. We saw a resurgence in the opiate overdose epidemic, and we've seen an increase in social and political unrest as we've continued to move forward. So what are the workforce challenges? For the community behavioral health system, 98% reported difficulty finding new clinical or medical staff. 88% reported that it was difficult to keep the existing staff. 77% reported increasing turnover, and 91% reported clinical positions were vacant for more than 45 days. But if we look a little deeper in that, what we found is almost 50% reported that they had at least one position that was open for more than 90 days, and some positions that have been vacant for more than 180 days. So once you lose a position, it's almost impossible to replace them. And it really doesn't matter what part of the state you're in. We're seeing different issues in urban areas than we're seeing in rural areas. But at the end of the day, it's a people issue. So what makes recruitment and retention so difficult? So when you look here, what you'll see is the red and yellow are the key issues. So the biggest challenge was lack of qualified applicants, followed quickly by lack of applicants. So if you put those two together, the biggest challenge is we don't have people applying for jobs who are even applying, and if they do apply, it's questionable whether they have the qualifications. I would venture to guess that if we did this today, that the COVID burnout, or just burnout in general, would be a much higher number, because what we've seen is because of the decrease in the number of available staff, caseloads have increased, and people are doing more and working more hours and trying to meet the demand to the degree that they can. We all have this little problem of we have, superhero syndrome, right? We want to put on our superhero cape. We're helpers. We're going to help as many people as possible. And we have a hard time taking off the cape and remembering that we're just one human being doing the best that we can, and that it's okay to take care of yourself. Some other challenges that come up, and this is the one that I think we probably have the most ability to control, but it's one of the hardest we have, but it's the lack of professional value. When we talked about we're essential healthcare workers, sometimes we're recognized as essential healthcare workers, and other times it's like, well, you're not a healthcare professional. So I'll give you an example. This is one of my favorite ones. It's terrible. During the early days of the pandemic, do you remember when Starbucks was giving free coffee to essential workers? You walk in, you show them your badge, they'd give you a free cup of coffee. So we had somebody who walked in, they had their community mental health center badge, they showed their badge, they said, I'd really like my free cup of coffee. They're doing community-based work, crisis services, all this stuff. And the person behind the counter said, "Thank you for doing God's work. That'll be $5. This is the value proposition. How do we really make brain health, mental health, substance use, their chronic health conditions part of our vernacular as, yes, we are absolutely essential to the healthcare space? Pandemic stress, I've alluded to this. The helpers were experiencing the exact same thing that everybody, all of the rest of us, and the people we were trying to help. So the work-life balance, childcare issues, all of that at the same time we know was very much impacting our workforce. And people really philosophically making different choices around who they, where they want to prioritize their time. One of my favorites, insufficient insurance coverage and reimbursement. How many times do we start a conversation with somebody who's seeking help with, tell me what your insurance is? Because depending on what they say, depends on where you send them and how you track them down. We know this is the lack of parity is one of the key challenges that we face. We also know that it's not just that the insurance companies don't recognize the full range of professionals, they also don't provide the full range of coverage and services that we provide in a community-based system. We're the only sector of healthcare where Medicaid is the preferred payer. In any other specialty area, Medicaid is not the preferred payer. The commercial payer is. So how do we deal with this? We also know that this is driving a new phenomenon into more professionals are providing cash-only services. So in many communities, and maybe it's true here, it certainly is in my community where I live, if you want access, you better be willing to pay cash. And you're probably looking for a psychiatry appointment, $450 for the first appointment and $125 for every hour of counseling. But if you want access, that's what it's going to be. And I can tell you from personal experience, even in that market, when you have good health insurance, it's still a 4 to 6 week wait. So there's no silver bullet here when it comes to this issue of insurance. The other thing is we have a lot of barriers with professional licensing. How do we move people quickly and rapidly through the process so that we can get more people when they've completed a degree into the field so that we can rapidly create those on-ramps for people into our service delivery system? So those are the challenges, and they're big, and it's going to take all of us. But we want to spend a few minutes talking about some of the solutions and ideas that we're putting forward. So the first is really infrastructure development. We're waiting right now. We have had approved $85 million in ARPA, Home and Community-Based Services funding to support the workforce. The federal government has approved the spending. Now we're just waiting on the General Assembly to appropriate it. So calls to your elected officials in the next couple weeks when they come back after the election to appropriate these dollars would be a well-placed call would be welcome. We also know that it's not going to be just dollars and cents, right? We have to also think about some of those other values of life, things that we can fund, because we're not going to be able to just raise salaries, because in an environment where your payment models are all capitated based on Medicaid, you get a fee schedule. Insurance, you have a flat rate. Those don't change just immediately. I'm not like McDonald's where I can raise the price of my fries by 50 cents to cover the increased cost of buying potatoes. All of the same inflationary costs that every business is experiencing, community behavioral health providers are experiencing. But we don't have the ability to increase our price in order to cover those expenses. So we've got some other things. Are there ways that we can look at cost of living incentives or stipends, paying for internships, funding programs, and really starting to highlight the value of behavioral health? Parity enforcement has to be a key priority. We have to have the commercial insurance companies paying on par with Medicaid, if not better, and they have to start recognizing the wider range of our workforce. We have to have the ability for the dependently licensed practitioner to be able to be recognized and their services covered. We have to continue to remove administrative barriers. Looking at applications for licensure, can we create more on-ramps and off-ramps? How do we start to think about bringing dependent licensed people and really allowing people to practice at the top of their license? We talk the talk, but we haven't really walked the walk, particularly outside of the Medicaid program. We have to create new resources for providers that train students. We know that community behavioral health is the training ground, so let's make that a business line. Let's pay the providers for doing that training and supervision and building the generation of workforce, knowing that hopefully some of them will fall in love with the work, they'll fall in love with the communities, and they'll stay, because that's really what we need. And then we have to continue to look at our documentation requirements and continue to make that much more efficient. We have to look at new reimbursement models. There's a variety of things in terms of ways to create incentives, but we have to also look at models that will pay for, benefits, education experience, really a look at aligning that risk sharing so that you're focusing on outcomes, but you're also making sure you're recognizing the amount of risk it takes with the workforce. And then there's a new model that's been put forth nationally called Certified Community Behavioral Health Centers. That's an integrated whole person care model that really offers an opportunity for Ohio to really rethink the way we deliver comprehensive care. We have to work with our academic institutions at all levels, from the community college to the 2 and 4 year colleges to advanced higher ed, and really create different collaborations. We need partnerships. Our academic institutions, they want to recognize us as businesses, but we don't always think of ourselves as a business. So how do we take that business need to our academic institutions and really build those on-ramps and off-ramps so that a person can decide, I'm going to get my associate's degree and that's my stopping point. Someone else may say, I want a PhD and that's my stopping point. But how do we build everything in between so that we can meet the needs of people, that if they need to exit, knowing that our workforce is predominantly female, how do we think about that as a career opportunity that people may need to exit for a period of time, but may want then an on-ramp to come back? And so how do we make that work? How do we pay for internships? How do we think differently about continuing ed and opportunities at all levels and across all of the various degrees? Love my psychology department. I have a degree in psychology. When you graduate with a bachelor's degree, what can you do? Almost nothing other than case management or work in residential treatment. Can we change that? Can we create a credential that gives a person a scope of practice and allow them to have that viable career? Because they want to be helpers. That's why they got the degree. So I'll end with this. Governor DeWine, in his State of the State, spent almost 15 minutes talking about mental health and the behavioral health system. And it was about fulfilling a decades-old promise. And one of the things he said was, our system isn't broken, it was just never built. And I think that is absolutely true. But in one of the visions that he laid out, and I think this is really important, it's that we have to have the best, most robust behavioral health workforce in the country. A workforce that is hailed as heroic and valued as a vital part of our health system. That's the first time that we've ever had a direct call out about the importance of the value of having a behavioral health workforce. So we have all of the right things before us to really start to make the difference. But this is really what it starts with. We have to value the people, and we have to create an interest in people coming into these professions, whether it's psychiatry, whether it's nursing, social work, counseling, vocational rehabilitation, addiction treatment. People who want to be professional case managers, we need a role for them. And we have to have folks wanting to do direct service. One of the biggest challenges in the post-COVID era is people don't want to work 24/7. They don't want to have jobs that require them to be on call. They want to have work-life balance. Yet people's mental health and substance use conditions don't neatly fit in a box between the hours of 8 and 5. So how do we create the incentives? Those are the challenges that we have before us in creating value and flexibility to bring the workforce together. The longer report that we have is available, and I think you'll have access to these slides. And with that, we'll open it up for a dialogue.
Okay, so the way that we've organized this day is to give folks a lot of time to engage in that dialogue. And we've got about 25 minutes here with Theresa. So we encourage questions, observations, any reflections on what she shared, and you've certainly shared a lot of information. While you're thinking about maybe a question to pose, I'm curious. You laid out a lot of fertile ground for advocacy. And with the upcoming operating budget, I'm wondering what, where your highest priorities are, and if you could talk a little bit about that. And I'll come around with the mic. Just put your hand up, and I'll come over to you so that folks online can hear your questions.
Sure. So, as Tracy mentioned, we do have the upcoming state budget will be released in February. From an advocacy point, we also have a whole white paper on our policy priorities. But the three biggest things, the first is workforce. And the things that we're thinking about there are more structural in nature. So how do we start to look at state licensing boards, and are there ways we can accelerate people into career pathways? And I'll give you an example. We know that at the dependently licensed practitioner level, particularly for counselors and social workers, you have to pass a test. We know that there are some cultural biases in those tests, right? I mean, I'm a social worker. When I took the test, the first thing they told me in the career prep class was, if you're in clinical practice, forget everything you know. We shouldn't have a test that requires just a regurgitation of information based on an academic planning process. It should be applicable. And we know that, at least for social workers, that ASWB, the American Social Work Board, recently released some data that shows that about 20% of people simply will never pass it. And if you're a person of color or a person, it's even less likely. So the state of Illinois recently passed legislation that removed the requirement for that test at the dependently licensed level, because you're always going to practice under somebody who's independently licensed, right? The first month that that law was in effect, they added 900 social workers, and in the first quarter, they added 2,100. So that's an idea that we're looking at in terms of how do we do that. The thing about, people who have degrees in psychology or degrees in, sociology, people who want to be helpers, can we create a licensure pathway, a scope of practice for the qualified mental health specialist, the QMHS? So that's another idea. Those are big and bold. It's going to take a ton of work, but that's one that we're talking about there. The other one that really has to be part of the solution is parity. We have to have enforcement of insurance parity. We've been working with the Department of Insurance around an actuarial study that's looking at rates that are paid in the commercial market compared to the Medicaid rates. And we know, based on national data, that psychiatry in particular is paid 80% of what primary care is. So if you understand that primary care is not the best payer and psychiatry is getting 80% of that, we understand that this is part of the challenge. So if we're going to bring professionals back into the space of serving people with an insurance product, then we have to start to address these issues. So parity has to be part of the solution. And then, because so many people in community behavioral health are dependent on Medicaid, we are also going to be looking for rate increases. Our strategy is probably in the 3 to 5% of across the board. And then are there some targeted areas where we need to really make immediate adjustments to just keep the workforce that we have? So those are probably the three big areas. And then the Certified Community Behavioral Health Center is another service delivery model that we're looking at expanding, because it does bring together comprehensive primary care, behavioral health, and it comes with a prospective payment model, much like the FQHCs. So it would put community behavioral health on par with the federally qualified health centers.
Oh, there's a question online.
So the question is, there is a lack of health literacy in a lot of rural areas. Are there any ideas of putting more community health workers in rural communities?
So absolutely, I would say yes. And I think we talk about it in terms of community health workers in the behavioral health space. I would say that is our peer workforce. And I think that's an area where we are working to build the peer workforce to work with individuals who have lived experience in substance use, but also family peers and mental health peers. Of course, we have a reimbursement issue and challenge with paying for mental health peers and for family peers. So I think one of the other challenges, long term, is we like to name things different titles and different, areas, so we get confused. I think our peer workforce would be benefited if we talked about them as community health workers as well.
Hey, Theresa, this is Melanie from Paint Valley Adam H. One of the things that we see, and I didn't know if if there's any advocacy being done on this, is Medicare's inability to recognize an independently licensed counselor really hurts our aging population, and we seem to have more counselors than social workers. And is there any advocacy being done in that area?
So yes, there has been, for 16 years, there has been a bill in Congress to add counselors and marriage and family therapists as eligible providers in the Medicare program. We know that if we did that in Ohio, it doubles the available workforce. We have passed it 7 times in either the House or the Senate, but never the House and Senate in the same year. So there is widespread recognition that we need to do something. So actually, CMS, the Centers for Medicare and Medicaid Services, passed an updated their calendar year 2023 physician fee schedule. Their final rule was filed on November 2nd. And for the first time, they will recognize general supervision for any behavioral health provider. So what that means is you can basically bill incident 2, but under general supervision, whereas historically it was under direct supervision. That's important, and it's an important distinction, because under the Medicare regulations, if you billed incident 2 under direct supervision, the physician or psychologist or nurse practitioner had to be immediately available and on site where the services was provided. This new rule that will go into effect in January says it can be general supervision, meaning they just have to be supervised. The billing would still have to be done under the physician, nurse practitioner, or psychologist, but it opens it up to everyone for a benefit that's covered by Medicare. Recognize Medicare's benefit is still very narrow. But it's a step in the right direction. It's a signal to Congress from the administration that we have to do more.
Hi, I'm Eric Johnston. I'm a social work professor here at OU, and I also work PRN for Ohio Health Hospice. So I'd be curious to hear a lot of discussion on workforce availability and entry. So I'd be curious to hear your thoughts on how you balance preparation for workforce with getting people into the workforce as far as behavioral health provision, so that then they are prepared to not do harm to clients, while also not trying to gatekeep the profession. I can even tell you anecdotally, I've never had an advanced standing student come through who has a bachelor's in social work and is then providing behavioral health service who says, I was ready. And so how do we then balance as professionals, as providers, the preparation to not do harm or to provide more services while also increasing the access to services?
No, I think that is one of the big challenges that we have, right? And it is, so much of the preparation and training is dependent on those clinical placements. And so I think this is where community behavioral health is well suited for being a good partner. And I think we had historically great partnerships. I think those have declined over time. And so how do we rebuild those relationships where you have people working in that team-based care environment? One of the benefits of community behavioral health, the reason I love it and I'm so passionate about it, is because it is team-based care. So it's how do we create those opportunities and different feedback pathways between the academic institution and the training location, and then making sure that there's good feedback around what are challenges or opportunities for growth for professionals. We also know that when people come into practice, we need to build out that training supervision for folks who are seeking advanced licensure. And that's something that we do well, but as we, the cost of doing that continues to rise, and we've got fewer people, what we're seeing is a decline in that level of supervision. So one of those things is the paid internship, and the, part of the $85 million that's proposed is about $45 million goes to academic institutions to fund the internship. The rest is also going to community providers to pay for the supervision. So that's one of the challenges that we have to do. But there's a new phenomenon that we're trying to figure out how to deal with, which is the person leaving with their dependent license, moving immediately into private practice. And that's a real concern for all of us from a safety perspective, from a How do we start to think about that? And that's going to be a policy solution we're going to have to work collectively to address, especially as we're seeing more and more clinicians want to move into, cash only private practice because it's lucrative, right? But I think that's also something, as we talk about team-based care, working with our academic institutions to make sure that we're training people on team-based care, because that's really where we know that people are getting that level of, understanding about whole person interventions, right? It's not just treat the brain and the body gets better. Sometimes you have to treat the physical health conditions at the same time you're treating the mental health or substance use condition.
Questions? Oh, hang on one second.
Theresa, thanks so much. I wanted to go all the way back to the beginning where there was sort of a bright side or, maybe a forward thinking part of this. I just wondered what your thoughts are on addressing prevention and, how we're ever going to get to that point of wouldn't it be great if there were a proactive side to what we're doing? I mean, I recognize the current challenges, but I'd just like to hear your thoughts on that a little bit.
Oh boy, I could spend an hour talking about the value and importance of prevention. It's absolutely where we need to be. The challenge we have is in a budget cycle. Everybody is looking for a quick fix. There is no quick fix. When you engage and invest in prevention, it's like planting a tree that's going to bear fruit in 10 years or 20 years. It's decades down the road. But many times, particularly in an environment of term limits in state government, people want to, they're looking for the quick fix. They want to see the bright, shiny object, right? How do we stop this issue over here? I'll give you an example of where we see challenges. The opiate epidemic. We have legislators who want to know, why haven't we solved the problem? Why does it get worse? It's a chronic health condition. Did you expect us to solve the problem of diabetes or cancer? Because we're still dealing with those issues. They're ongoing chronic health conditions. So we have to deal with prevention in the same way. We have to make sure people understand that this is like any other chronic health condition, and if we treat, it doesn't matter what we treat. If you're treating bullying, if you're treating substance use, if you're treating mental illness, depression, suicide, the rising tide raises all boats. The strategies that we teach our young people will benefit all of those conditions, regardless of which one, a school district, a university, a pediatrician's practice, regardless of what they pick. We need to make the investment. We need significant investments. In Governor DeWine's first budget, there was a $650 million investment in the Student Wellness and Success Fund. It's the first time we'd had any, incredible investment. Did it work the way we wanted it to? Maybe not. But what happened in the last budget? All of that money got sucked into a category called Disadvantaged Pupil Impact Fund. I hate the name, but it also means those dollars got kind of watered down because they're also used to fund public preschool. They're used to fund smaller class sizes, reading intervention programs, after school programs, all necessary, all helpful. But in terms of doing real prevention work on a daily basis, that's primary prevention, and then doing screening and identifying, young people sooner, we have to make the investment. So yes, it's in our policy solutions, there's a whole strategy on prevention, but it's a real hard sell in our public policy today.
It's very interesting that you use the term watered down. Cynthia, who's participating remotely, had a comment, and she said it is a concern how we maintain a qualified workforce when the qualifications of those providing these services are reduced. This has occurred in some fields, and the results are not always positive for those we serve. They get what many refer to as watered down service.
It is the challenge that we have, maintaining the quality and the professionalism as we're also trying to bring people in. I didn't, you know, I have a daughter who's 15 and she's doing the career exploration and she's looking at all kinds of stuff. And, you know, because her mom's a social worker, she looked at what social workers make. And she came home and she said, Mama, why did you choose to do this? Social workers make less than teachers. So that's the value proposition that we have to change the narrative. And so that's the work that we have before us, is really recognizing and elevating the value of the work that we do. I think talking about it as brain health is an interesting dynamic. It's a shift. If we're in the healthcare space, we talk about heart health, we talk about breast health, we even talk about prostate health, but we don't talk enough about brain health as an essential part of the work that we do.
Hi, I'm Ty Ingram with Pickwick County ESC, and we work closely with Adam H. and Melanie and her group, and I think we're probably on 149 different committees together. But we just hired our first social worker, and she's online here watching from Circleville, our alternative school. And I guess this is more of a comment, but then a question. Brian and I are talking. Brian's an educator. He's a superintendent of Wellston. So those DPIA dollars, or maybe they call them DPIF dollars now. They used to be DPIA. We need those. We use them. But we also need to be able to meet students' behavioral health. So how do you, for those of us who maybe don't have the connections with the behavioral health specialists in our area, how do we start to make those contacts, and what should be our first steps?
So you know, just to be clear, we know we need those dollars. We just needed them to be increased and to keep the prevention dollars. It's a both and, not a replacement, one or the other. I think the important part is, you know, connecting through the community providers. The biggest challenge is, though, goes right back to the 380 to 1. We have, you know, we also do a study every year of the number of community providers who are in schools doing school-based services. And in 2021, when we did this study in February, we knew that we had, I think, 74 organizations that responded who serve kids. Those 74 organizations, which is just a part of my membership, so it's not everybody that's serving kids, were in 73% of all Ohio school buildings. And we talk about it at the building level because we know it's building by building. So there's probably somebody there or somebody in your community, but we still come down to the base issue of, even if there's resources, whether it's from the school or from the Adam board or from a foundation to serve kids in schools, it's finding the person who's willing to do it and who can be there more than a couple hours of a day. A couple hours is great if we're going to do primary prevention and you're targeting where you're going. But I'd say connect with your community providers, work with your Adam boards to find out who they are and make those connections to their kids services programs. You know, you can also reach out to my organization and we can help connect you to that. We have that survey of schools is posted on our website, and it gives you the school lead for every provider that responded.
Hi, I'm Chris Bart, Professor of Counselor Education at Ohio University. Thank you for setting the scene so well for us. I think, like John mentioned, prevention is something that occupies our minds a lot as well.
Sure.
And I think that finding pathways for associate degree workers or bachelor's level trade workers would be the way to go. And I'd definitely be interested in talking with partners about how to make that happen, including you, Joe. We've had some good conversations. And I wanted to add that the American Counseling Association has been working very hard at the national level for access to Medicare for counselors. And from whatever I hear, they seem to be very optimistic this year. So I think participating in advocacy at the national level on this issue is very important. Thanks.
Other questions? Oh, 1 second.
Hi, I'm Stephanie Sarcher. I'm the superintendent of Fort Fry Local Schools, and actually we'll be talking at lunchtime. And Justin and I are in the school systems, and we were just talking about there are programs that sponsor internships for juniors and seniors, and most of us have a affiliation with a mental health provider in our school systems, and we are finding that they're not able to. What gets in the way of taking those internships is HIPAA and that confidentiality piece. And so I don't know if there's anyone in the room that are able to offer those internships at the high school level to like a senior student, or if we know of a model that works. But you know, we have found in schools, whether it's a Grow Your Own for Teachers pipeline or a Grow Your Own career, some kind of career tech program, that that is a great way to encourage young people to go into the workforce. And when they do the internship, they can roll out if they like it or not, which is good, because then they don't go to college and spend that money on post-secondary training. But we don't know how to work around that whole HIPAA confidentiality piece.
Yeah, that is one that is a challenge. It's also, there are requirements in order to be an eligible provider and seek reimbursement. You have to be at least 18. So it's kind of a double-edged sword, but something we can certainly look at from a policy perspective to see if there's any ways around that. But I think the minimum age of 18 is also a federal Medicaid requirement.
Theresa, another comment from the chat from Marcia. She says community health workers are trained in informal counseling, which can help the client until they can get into professional help. We often help them make appointments, but it takes so long to get in to see someone. Perhaps the community health worker can be the person that can help as an in-between.
So I think community health workers and the peer workforce are vitally important, and we don't have enough of them, because it is using that lived experience or the community experience to walk beside the person and provide that support and informal connections to services, because it is taking a long time. I mean, what used to be days and weeks to get an appointment is now weeks and months. I mean, in many communities, if you are looking for a psychiatrist, it's 6 to 9 months, which is terrible. Unless you're in a crisis, you know, that's how you get that's how you're accessing care today. Otherwise, you know, counseling times, it varies organization to organization. We don't have good consistent metrics from community to community. But you know, we know it's weeks, because go back to the math problem, 380 to 1. As one person, if I saw a client once a month, which is not the typical you know, cadence for which you see clients, I'm still not able to treat 200 people of that 380.
Got another question back here.
Doug Pfeiffer, I'm the CEO of Life and Purpose Behavioral Health in Marietta, Ohio. And I think you're talking a lot about the workforce being a problem, but I also think that just screams more prevention and reprioritizing what's most important for kids. And that's like in the system of education. I consult a lot with schools doing training and supervision and consulting, and have, you know, mental health providers in the systems. And that's all well and good. But when teachers are afraid to let a kid out because it might impact academic progress, even though they're not making any academic progress to begin with, you actually inhibit that. And but I think that's a systemic issue where we're still prioritizing academic achievement over the well-being of a child. And so if we figured out ways to evaluate schools in terms of how are we promoting wellness in our students, I think you'd start seeing, because we're never going to keep up with any of this. You could, you know, come up with many different ideas, but it's a prevention issue, and it's prioritizing what's most important. And we all know that a 4.0 GPA doesn't guarantee a successful employee. when they get out. So we obviously have to rethink about how we prioritize, and those are systems. Everything we've all tried to do gets blocked by systems in terms of the way they look at those things. And so along with parity, I think systemic change in multiple systems, not just the behavioral health system, but the educational system, all these different types of systems, I think are going to be critical.
I couldn't agree with you more. And the other thing, so in the through the Department of Education, they released their Whole Child Initiative, which actually includes an entire component around social emotional wellness as a critical component to academic success. It's become highly politicized, unfortunately. But that's really what we're talking about. When you look at the whole child model, and it's not just academic success, we know that just like if you're hungry, you can't learn. If you're traumatized, if you've got the fire alarm in your brain going off because of anxiety, depression, community violence, family violence, whatever happened, whatever's triggered you, you're not learning. It's no different. We've got some strategies that have been put in place from a systems level. There are training and resource and toolkits. I've been personally involved in some of this work at the state level, but we're a home rule state, right? We have 685 different districts, municipalities, private, public funded schools. So it's how do we do that one by one? And then how do you do it building by building? And then because it's been tied under critical race theory, that social emotional learning is indoctrinating children. There's a whole website on this if you haven't seen it. It's terrible. But those are real challenges that we face in terms of trying to put prevention services in school. I've had providers call me and say, we can no longer do, a suicide intervention program because it's been labeled by our school board as part of CRT, critical race theory. So these are the challenges from a political standpoint that we're also struggling with, because absolutely I agree, we have to make this prevention. Why can't we get our pediatricians to screen? Because we don't get paid for it. How do we make sure that who pays for prevention? It's not a covered healthcare service in the way that we screen and prevent for physical health conditions. We've made it payment for autism. Everybody does the MChat now, right? So there's screening for this, but how do we do this on a regular basis? So these are some of the real challenges, because, I'm a firm believer that which gets paid for happens and that which gets measured changes. But if we don't pay for it, it's unlikely that it's going to happen on the scale that we need it to. And that's where we all have to collectively use our voices to say, this is what we need. We have to demand payment for prevention. And it should honestly be paid as a healthcare service. Back to, is it brain health or is it social service? It's just something the school should take care of. No, it should be part of every fabric of our community. I won't get on my soapbox.
Theresa, I have two comments. One is specifically related to what you were just talking about, and then there's another question. Marcia says, I'm a teacher too. From my experience, there is one counselor per school or district. Teachers definitely do not mind if a student would need to leave the room to get counseling. We would love it. There just are not enough counselors per school. Mm-hmm. And then Autumn has a question. She's from Humana. How are Medicaid providers able to help with this process? What are some of the resources we need to look to prioritize to be helpful in the process?
In the prevention process?
I'm assuming
I would say
yes.
if it's in prevention, they could choose to pay for preventative care services. And there are a whole series of codes that are available to pay for that. And that is the benefit of managed care, is they could choose to pay for that.
If I get a response, I'll tell
Okay. The issue with counseling is, you're right. I mean, it's a shortage of school counselors. We also are very strong believers in the school community partnership, because the other thing with having counseling available is when you're connected to a community provider, it means that child has access to the service 24/7. 365, not just during the school day or during the academic year, because that's one of the challenges. We need the school counselor, we need the school social workers. They have a vital role to play in the building, but we also know we have lots of community providers who are entering the buildings and very willing to do it. Assuming we have the workforce and the people to do it, we know that those connections really help kids and it helps their families. We know school-based care overcomes a lot of barriers, transportation being the biggest one, because kids are already there. So if we can do it during the day, some teachers really are open to having students leave. Others are like, I've got to have their butt in chair because we've got to achieve this grade and we've got to get this done. So it's really the culture of the school and how do we work by that. And what we know in terms of working with community providers is it's building by building. It really is principal by principal and district by district.
We have reached the balance of our time here with Theresa this morning, but I just want to take a moment and thank her for all the information that she's provided and the insight.